Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Usually, when we think about surgery, we have this expectation of a really simple, clean subtraction.
Right, like taking out a diseased appendix or something.
Exactly. You have a diseased appendix or, even just a splinter. You take it out and the problem is essentially solved.
Yeah, the body just kind of goes on functioning as if nothing really happened.
Right. But when you step into the world of upper gastrointestinal surgery and specifically the stomach, that simple arithmetic just completely breaks down.
Oh, absolutely. Because you aren't just leaving an anatomical void.
You're rewiring a patient's entire metabolic reality for the rest of their life.
Yeah, it is the absolute definition of a physiological puzzle. I mean, you solve one structural crisis, but you instantly create a brand new metabolic baseline.
And that is exactly what we are exploring today. We're looking right at you, the medical professionals tuning in.
Right, whether you're a seasoned surgeon reviewing your foundational principles or a doctor catching up on the latest clinical indications.
Exactly. This deep dive into gastrectomy is tailored specifically for you. And before we begin, a quick reminder that this content is for reference only. Please ensure you always follow local guidelines in your own clinical practice.
Which is really essential context, because the landscape of upper GI surgery is constantly shifting based on those very guidelines.
Right. I mean, what used to be primarily a brute force treatment for bleeding peptic ulcers has evolved so much.
It really has. Today, it's this highly nuanced procedure spanning aggressive oncology, preventative genetics, and even complex metabolic disease.
And that's our mission for this deep dive. We want to understand the clinical tension at the heart of this procedure.
A balance, right?
Yeah, exactly. How do you balance the absolute eradication of a disease with handing a patient a completely new physiological reality?
Well, to understand that tension, we really have to start with the architectural blueprint.
Right. And I want to skip the basic anatomy here.
Yeah.
We all know where the fundus is, and we know the difference between a total and a distal resection.
Sure. I mean, we've got the four main types. Discal or subtotal, where you take the antrum.
Total, obviously, where the whole thing goes.
Right. Proximal, taking the cardia and fundus.
Mm-hmm.
And then the sleeve, where you do that longitudinal cut along the greater curvature.
Leaving just that narrow tube. But what stands out in the current clinical data isn't really the architecture itself, but the method of delivery.
Oh, you mean the shift toward minimally invasive approaches?
Exactly. I mean, laparoscopic and robotic surgeries are becoming the standard in so many centers now for early gastric cancers and bariatrics.
Yeah, to reduce pain and hospital stays.
But with these new approaches, I've got to ask, are we actually changing the nature of the surgery or just the doorway we use to get in?
We are absolutely just changing the doorway.
Really? No structural difference?
No, the underlying oncological and architectural principles, they remain rigidly fixed. I mean, whether you have a massive laparotomy incision or, 5 robotic ports.
It's the same job on the inside.
Exactly. If you're performing a distal gastrectomy for cancer, your margins, your anatomical boundaries, your lymph node dissection goals, none of that changes.
So the biological goals are identical, even if the patient's recovery time drops significantly.
Right. The principles are the same.
Okay, so the biological goal is the same, but the physiological impact is still profound.
Oh, for sure.
I used to think of a gastrectomy kind of like remodeling a house, knocking down a wall here, taking out a room there. A distal is taking off the back extension. A total is knocking the house down to the foundation.
And a sleeve is like putting up a massive partition wall down the middle.
Exactly. But looking at the lifelong systemic impact, that feels way too mechanical.
Yeah, it doesn't really capture it.
It feels more like ripping the alternator out of a car. Like the engine might still run, but the electrical system, your metabolism, your iron absorption, all of it starts shutting down unless you manually bypass it.
That is a much, much more accurate way to look at it. You are taking out a central regulatory hub. And that metabolic cost is exactly why the indications for these structural resections have to be so ironclad.
Because you don't remove the alternator unless the alternative is the car catching fire.
Exactly.
Yeah.
Which brings us to the primary reason we actually perform these surgeries today.
Right, the malignant frontier. Gastric cancer is the most common global driver.
And this is where the surgical strategy gets incredibly specific.
Yeah, for discal gastric cancers, the goal isn't just taking out the tumor, it's achieving an R0 resection with clear margins.
But the margins are only half the battle. We have to talk about the lymph nodes.
Let's do it. Because that is where the real clinical debate seems to lie.
Yeah, the standard often pushes past a D1 into a D2 dissection.
And why is the D2 such a tightrope for a surgeon? I mean, why is it so hotly debated?
Well, the D2 dissection is the perfect example of balancing oncological clearance against surgical morbidity.
Okay, break that down for us.
So in a basic D1, you're taking the perigastric nodes directly along the lesser and greater curvatures. It's fairly straightforward.
Right next to the stomach.
But gastric cancer spreads aggressively through the lymphatic basin. So a D2 goes much further. You're clearing nodes along the left gastric, common hepatic, and splenic arteries.
Wow, which is a much deeper dive into the vascular anatomy.
Exactly. And the clinical tension here is that historically, clearing that splenic hilum often meant performing a splenectomy or even a distal pancreatectomy.
Oh, wow, which dramatically increases the complication rates, right?
Massively.
You're looking at severe infections, pancreatic leaks, and just huge postoperative morbidity.
Precisely. So the modern challenge for the surgical oncologist is achieving that thorough D2 nodal yield, getting adequate aggressive disease control while actually employing pancreas and spleen-preserving techniques.
Which requires incredibly meticulous dissection.
It's technically very demanding, yes.
Now, if the cancer is proximal or if we're dealing with a gastroesophageal junction tumor, the approach shifts entirely.
Oh, completely. It changes the whole operative field.
Let's dig into serotyping for GOJ cancers. I know type 1, 2, and 3 dictate the surgery on paper, but how does that actually play out in the operating room?
Well, how does the tumor's physical position shift the surgeon's approach?
Yeah, exactly.
It basically shifts the approach between the abdomen and the chest.
Really? Just based on the type?
Yeah. So SEER type 1 tumors are essentially distal esophageal adenocarcinomas that happen to cross the junction.
They grow upward.
Right. So the surgeon typically has to go into the chest, often performing an Ivor-Lewis esophagectomy.
Okay, so you mobilize the stomach and the abdomen, then open the right chest to resect the esophagus.
Exactly. And then you pull the stomach up into the thoracic cavity for the anastomosis.
But a type 3 is fundamentally different.
Right. A type 3 is a subcardial gastric cancer that infiltrates upward into the junction.
So it's a stomach cancer acting like an esophageal cancer.
Precisely. For these, you generally stay in the abdomen, you perform a total gastrectomy with a transhiatal resection of the distal esophagus, and just pull everything out through the belly.
And what about type 2?
SEER type 2 is the true junctional tumor, and that is where multidisciplinary tumor boards really earn their keep.
Debating whether a thoracic or abdominal approach will get the best margins.
Exactly. And while preserving the most function for the patient.
It really emphasizes that this isn't just stomach removal, it is an en-bloc oncological resection.
Combined with perioperative chemotherapy, usually, yes.
But here's the clinical scenario that I find incredibly heavy, and this is where it gets really interesting.
Oh, the genetic indications.
Yeah. We're talking about prophylactic gastrectomies for patients with the CDH1 mutation, which drives hereditary diffuse gastric cancer.
Right.
You're a physician sitting across from a 25-year-old patient, advising them to undergo a total gastrectomy when their stomach currently looks completely healthy.
It's a huge thing to process.
For a doctor advising a patient, how do you contextualize removing an entire organ prophylactically based on a mutation? How do you justify trading a fully functioning organ for guaranteed surgical morbidity?
It is one of the most difficult conversations in medicine, honestly. But what's fascinating here is that it comes down to the insidious biology of diffuse gastric cancer.
Because it's different from standard gastric cancer, right?
Completely different. Intestinal-type gastric cancers, they usually form a distinct mass or a visible ulcer.
So you can see it.
Right. You can scope the patient, see the lesion, and biopsy it. But the CDH1 mutation drives a diffuse-type cancer.
What does that mean exactly on a cellular level?
It begins as microscopic clusters of signet ring cells that spread laterally, deep beneath the mucosal surface.
So they are essentially invisible to a standard endoscopy.
Completely invisible until they are dangerously advanced. I mean, you could perform a high-definition endoscopy with random biopsies on a Monday.
And get completely benign pathology back.
Yes, and that patient could still harbor aggressive microscopic cancer permeating the submucosa.
That is terrifying.
It is. And the penetrance of the CDH1 mutation is exceptionally high. By the time the patient becomes symptomatic, by the time the stomach becomes rigid and won't distend.
What we call Linitis clastica, right?
Exactly. By that point, the disease is often incurable. Therefore, the prophylactic removal following genetic counseling is a radical but entirely necessary life-saving intervention.
So we take the stomach out in those cases to outrun an invisible cancer.
Yes.
But what happens when the stomach isn't malignant, but is fundamentally destroying itself?
You mean the benign and emergency indications?
Yeah. If we look at benign and emergency indications, there's a fascinating historical shift here. Decades ago, complicated peptic ulcer disease kept GI surgeons constantly in the OR.
Oh, it was the absolute bread and butter of the specialty. Vagotomies and trectomies.
Surgeons were essentially doing mechanical plumbing to control stomach acid.
Exactly. It was a mechanical solution to a chemical problem.
But proton pump inhibitors and advanced endoscopy completely changed that landscape. I mean, pharmacology basically cured the standard ulcer.
It really did. The PPI era revolutionized things.
So what does this all mean for the ER doctor or general surgeon on call? What benign disease actually forces you to open the patient up now?
Well, you only operate when medical management completely hits a wall.
Like what?
For example, recurrent ulceration that causes severe fibrosis in the antrum.
Ah, so structural damage.
Right. Over time, that scarring creates a gastric outlet obstruction. The stomach physically cannot empty, and the patient presents with intractable vomiting and severe dehydration.
Got it. And what about bleeding?
Yeah, that's the other big one.
Huh.
You have a massive bleeding ulcer or a perforation where endoscopic clipping or interventional radiology embolization has totally failed.
What about benign tumors? We read a lot about gastrointestinal stromal tumors, or GSs. Can't you just do a simple wedge resection for those?
Often you can, but location and size dictate the limits.
So if it's too big?
If you have a massive GS, or say one located right at the gastroesophageal junction, a simple wedge resection might completely deform the junction.
Leaving the patient unable to swallow.
Right, or suffering from catastrophic reflux. In those cases, you are forced into a formal proximal or total gastrectomy just to preserve functional plumbing.
And then you have the true anatomical rescue missions, the extreme scenarios.
Oh, like ischemic necrosis or corrosive chemical ingestion?
Those are the absolute nightmare scenarios on call, right?
Yeah, they are. If a patient ingests a strong acid or alkali, the chemicals cause transmural necrosis of the stomach wall.
The tissue literally dies.
Yes, the patient goes into profound shock and sepsis. And at that point, you aren't operating to cure a disease.
You're operating for damage control.
An emergency total gastrectomy is performed simply to remove the necrotic source of the sepsis and save the patient's life.
Wow. And do you reconstruct right away?
Almost never. Reconstruction isn't even attempted until they stabilize weeks or months later in the ICU.
Okay, so we've covered resecting the stomach because it's harboring a tumor or outrunning genetics, and removing it because it's necrotic or obstructed.
Right.
But let's pivot to what might be the most fascinating evolution of this surgery.
Bariatrics and metabolic surgery.
Yes. Taking a completely structurally healthy stomach and permanently altering it to treat severe metabolic disease.
The bariatric field completely redefined how we understand the gastrointestinal tract.
I'll admit, for a long time I thought procedures like the sleeve gastrectomy, where you remove, 70 to 80% of the stomach?
Yeah, along the greater curvature.
I thought it was just about physical restriction. You make the tank smaller, the patient gets full after 3 bites, and they lose weight.
That's a very common misconception.
But looking at the clinical data, that mechanical view seems completely inadequate. Wait, if we connect this to the bigger picture, we aren't just creating a smaller pouch so people eat less. Are we actually performing endocrine surgery here?
Yes. And framing it as endocrine surgery is the only accurate way to understand the clinical outcome.
Because we're altering hormones.
Exactly. If it were just about a smaller tank, patients would feel constantly starved and miserable. But that isn't what happens.
Because of the ghrelin, right?
Right. When you resect the fundus and the greater curvature, you are physically removing the body's primary source of ghrelin production.
Ghrelin being the hormone that signals hunger to the brain. We are literally changing the body's chemical communication.
Exactly. It's an orexigenic peptide. By excising the ghrelin factory, you chemically downregulate the patient's appetite.
That is wild.
But it goes far beyond just hunger. We see rapid improvements in insulin sensitivity and a reduction in type 2 diabetes markers within days of the surgery.
Wait, really? Within days? Long before the patient has lost any significant adipose tissue?
Long before.
How does cutting the stomach alter glucose metabolism so quickly?
It has to do with how the altered anatomy changes the transit time of food and the subsequent release of gut hormones.
Okay, walk me through that.
When food hits the distal small intestine faster, it triggers an amplified incretin response, specifically hormones like GLP-1 and PYY. from the hindgut.
Which massively boosts insulin secretion and sensitivity.
Precisely. So by altering the stomach, you're fundamentally rewiring the enteroinsular axis. You're changing how the gut talks to the pancreas.
It's incredible. And gastrectomy principles are also the foundation for even more complex metabolic surgeries, right?
Like biliopancreatic diversion with duodenal switch, yeah.
Where you combine that gastric resection with a massive rerouting of the intestines to induce malabsorption.
Yes. And in all of these metabolic cases, you are sacrificing healthy organ tissue to cure a sick systemic metabolism. It is a profound trade-off.
Which brings us to the inevitable biological bill.
The human cost.
Exactly. Whether you're treating a diffuse cancer, an obstructed ulcer, or morbid obesity, every single resection demands a reconstruction.
The plumbing has to be put back together.
And the biological bill always comes due. The surgeon must manage the aftermath.
Right, and that is where the lifelong functional sequelae begin.
Let's talk about how surgeons actually put this back together. For a distal gastrectomy, we've got a few options in the literature. Billroth 1, Billroth 2, and the Roux-en-Y.
True.
But there's a clear clinical trend moving away from the Billroth procedures. Why are surgeons abandoning them in favor of the Roux-en-Y?
It comes down to fluid dynamics and the devastating effects of alkaline reflux.
Alkaline reflux.
Yeah. In a Billroth 1 or 2, the remaining stomach remnant is hooked directly into the duodenum or a loop of proximal jejunum.
Okay, so it's a direct connection.
Right. But the problem is that bile and pancreatic enzymes are constantly secreted into that area.
And since you've removed the pyloric valve.
Exactly. Without a pylorus, those harsh alkaline secretions wash backwards into the stomach remnant and even up into the esophagus.
Causing severe alkaline gastritis, which I understand is incredibly painful and notoriously difficult to treat medically.
Extremely difficult. Meds like PPIs do nothing for bile reflux. The Roux-en-Y configuration elegantly solves this.
How does it change the plumbing?
You transect the jejunum and pull the distal limb up to the stomach, that's your Roux limb. Then you take the limb carrying the bile and plug it into the jejunum much further downstream, usually 40 to 60 centimeters lower.
Ah, so you've created a Y-shaped diversion.
Yes. That keeps the bile far, far away from the gastric anastomosis.
That makes perfect sense. And for a total gastrectomy, since there's no stomach at all, the standard is the Roux-en-Y esophagojejunostomy, right? Connecting the esophagus straight to the small bowel.
Right. Sometimes they create a jejunal pouch to act as a makeshift reservoir.
But regardless of the plumbing, the physiological toll is immense. Let's break down dumping syndrome, because any doctor managing these patients post-op is going to see this.
Oh, inevitably.
What is actually happening physiologically in early versus late dumping?
Well, dumping syndrome occurs because, again, you've removed the stomach's natural release valve, the pylorus.
Right.
Normally, the stomach slowly meters chyme into the duodenum. Without it, a hyperosmolar load of undigested food dumps rapidly into the jejunum.
Just all at once.
Yeah. In early dumping, which is usually 15 to 30 minutes after eating, that heavy osmotic load draws massive amounts of fluid out of the intravascular space and straight into the bowel lumen.
So the blood volume literally drops.
Yes. The patient experiences sudden hypovolemia.
Wow. So they get, what, dizzy?
They get tachycardic, diaphoretic, dizzy, and have severe abdominal cramping and diarrhea.
That sounds miserable. And late dumping is entirely different, right? That is a glycemic issue.
Correct. Late dumping happens 1 to 3 hours after eating. The rapid delivery of carbohydrates into the small bowel causes a rapid spike in blood glucose.
So the pancreas overreacts.
Exactly. The pancreas panics and secretes a massive bolus of insulin. But because the food transit is so fast, the glucose is absorbed quickly.
Leaving all that active insulin circulating in the blood with nothing to work on.
Right. And the result is severe reactive hypoglycemia.
Which brings us to the micronutrient deficiencies. The clinical literature highlights iron, calcium, and especially vitamin B12.
B12 is the big one.
I really want to focus on the B12 mechanism because it's not just about losing absorption surface area, right? It is a specific cellular loss.
It is an absolute biochemical necessity. The parietal cells in the body of the stomach secrete intrinsic factor.
An intrinsic factor is required to bind to dietary B12 so it can be absorbed later in the terminal ileum.
Right. So if you perform a total gastrectomy, the patient has zero intrinsic factor.
None at all.
None. So without lifelong parenteral B12 supplementation, usually via injection, these patients will inevitably develop megaloblastic anemia.
And neurological issues too, right?
Yeah, irreversible subacute combined degeneration of the spinal cord. It's very serious.
And iron and calcium take a hit too because they rely on the acidic environment of the stomach and duodenum to be converted into an absorbable state.
Exactly, an environment that gastrectomy has completely bypassed.
So as a doctor, how do you balance this? You have the immediate relief of solving a problem, like stopping a recurrent bleed or cutting out a suspicious ulcer, but you are handing the patient a lifetime of B12 shots, strict dietary limits, and the constant threat of dumping syndrome.
This raises an important question, right? It is the ultimate clinical judgment call in our field.
Yeah.
You always have to weigh the natural history of the underlying disease against this new surgically induced metabolic baseline.
Right.
If it's a T3 gastric cancer, the choice is clear. It's life versus death.
Yeah.
But in marginal benign cases, say, a severe refractory ulcer that hasn't quite perforated, you have to seriously ask yourself if the cure is worse than the disease.
Because you're curing a localized structural problem, but enrolling that patient in a lifelong systemic functional syndrome.
Exactly.
It really reinforces that while surgery might be an anatomical fix, it's never a clean subtraction. You are altering the entire physiological equation.
If we take everything we've synthesized today, the profound impact on ghrelin and incretins, the absolute necessity of intrinsic factor, the role in calcium and iron metabolism, it demands a total perspective shift.
What kind of shift?
Well, historically, medicine viewed the stomach simply as a muscular bag, right? A mechanical mixing bowl and an acid reservoir.
Right, just plumbing.
But considering its massive systemic reach, perhaps we need to elevate our view. We should really be viewing the stomach as a vital, complex endocrine organ.
Oh, wow. I like that.
Which means, conceptually, any total gastrectomy is fundamentally an organ transplant. You are just forcing the rest of the body to adapt to the sudden vacuum. It's an organ transplant without the new organ.
That is a fascinating way to look at it. An organ transplant without the new organ. That gives us a lot to think about. Listeners, if you liked this content, then do not forget to share it with at least one of your colleagues or friends and spread the word. Also, be sure to check out our YouTube and other social media pages. And if you're looking for more, do check our previous season and episodes, which have some very relevant topics. Keep questioning, keep learning, and we will see you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.